Welcome to the Equine Vet Connect podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. All right, welcome back to the Equine Vet Connect podcast. Dan Carter here at Countryside Equine Hospital. Got a great guest today, Dr. Ted Vlahos from Cody, Wyoming. Dr. Vlahos has Yellowstone Equine Hospital in Cody, and thanks for being here. Let's start off with that. Thanks for being on the podcast. Thanks for sharing your knowledge. We really appreciate it.
You're very welcome. Thanks for the invite, Dan. We finally get to meet pseudo in person, or yeah, it's been a blast. It's been fun with the Tenex procedure for the last 4 or 5 years.
So that's what we're going to talk about today. This is I always hate calling it a relatively new procedure because it's not exactly new, but it's gained a lot more popularity. I think the word's getting out on it. But we're going to be talking about Tenex, which is a minimally invasive procedure that we use for tendons and ligaments. Ted introduced me to it, I guess, about 1.5 years ago, maybe 2 years ago, when I was looking for some options. And it's truly changed how we look at some of these chronic tendon and ligament injuries. So let's start off. You're kind of, I'd probably call you the expert in this in the equine field as far as you've been probably using it longer than anyone. So let's talk about what is Tenex and some of the uses for it.
Yeah, well, first, just a little background on it. Tenex was really described and invented by my dear friend, Dr. Bernard Morey. And Bernie is someone that I've been so blessed to be able to call a friend. And please take a minute and look him up. Dr. Morey was chief of surgery at Mayo Clinic. Dr. Morey is, I think now there's 6th edition in his name of the textbook on the human elbow. The disorders of the elbow are in his name. He's the foremost elbow surgeon in the world. He was President Bush's surgeon. He did 6 total joints in President Bush and Barbara Bush as chief of surgery. I believe 2023 or 4 he was nominated or voted by the American Orthopedic Association as pillar of the profession. He's legend in human surgery, and a brilliant man and a humble man. And the lesson that I learned from Bernie after doing elbow surgery for 30 years, and as he had published and written and everybody contributed, he's like, there has got to be a better way than what the heck we've been doing for 30 years. And that impressed me. And I think there is probably the lesson of this podcast, right? What are we doing? And he said, there's just got to be a better way than fasciotomies and cutting tendons and all of the things we have all done for, I finish 38 years in practice next week as an equine veterinarian. And that impressed me. And so the procedure, they looked at how can we get rid of the nemesis of all tendinopathy, and we'll use tendons and ligaments in this synonymously for this discussion, is scar tissue. How do we get rid of it? How do we get rid of the body's response to all of injured tissue, soft tissue, is to form a scar? And how do we get rid of it? And there was nothing to do that we had no way to get rid of it. We know we can grow cells. We know we can grow stuff. We can put cells and growth factors in matrix, but we can't get rid of the scar. So they looked at the principles of cataract surgery and phacoemulsification of hard stuff, and how could you use ultrasonic energy to bust it up and remove it. And that's how it got started in 2010, got FDA approval, I think, in 2012. And they just started, the models were tremendous, and we'll talk further about that. But I got involved with it. Rich Redding was actually the first one to really dive into it in the veterinary space. And Rich published the Tenex feasibility study in 2019 as to how can we do this in the horse, and what are these results looking like? How well is it tolerated? And he had tremendous success. Unfortunately, Rich retired, and lost his long-term follow-up access. And we picked it up about that time. I was introduced to Tenex from the human space, and I've spent a lot of our career just kind of diving into some human technology. So we were introduced to this, and we've all struggled, and we'll talk about this further, with just that nemesis of scarring. And I just it really intrigued me that we could get rid of the scarring, and then what? Well, the then what is what happens to this voided tissue that we've just sucked out of this horse's tendon or ligament. And the studies they found in the at University of Kentucky in the rabbit models, and they translated to humans brilliantly, was that the space filled in with normal collagen at normal ratios. And that for me was a game changer. And I had my very first horse, was a lateral suspensory branch, a pretty nice barrel horse, really good barrel horse. And I couldn't keep this thing sound, and we're injecting and stem celling and doing whatever. And we just had recurrent injury. And I told the lady, look, there's this new procedure. And I mean, we're stuck. We're stuck with this case, and we'll address those later. And I did this one standing, which we'll talk about that later. I do a lot of them down now, but she, just because I'm a head trauma patient, and my wife after a brain injury. So I did this horse standing, and she ended up being number one 1D barrel horse in the country. And she subsequently earned $750,000, and she's still sound, and she's just a great, uh, NFR level mare. So that impressed me a lot. And we've been doing it for about 5 years. So.
I had a similar introduction to it. I had a chronic tendinopathy in the deep flexor tendon, and I had done all the same things, and I was just incredibly frustrated. And I had heard rumors about Tenex, and I can remember calling you up, and I was like, "Okay, how does this work? What does it do?" And I think we had a quick conversation. I was like, "All right, I want one," and like I had no, because I knew what I was doing wasn't working. Like that's what I knew. So I knew all I could do. The worst thing happens, it still doesn't work. But I learned quickly, like this technique works. Like that horse is still sound, still doing great.
Yeah.
But
Well,
yeah, I think
I'm a simple guy, and I explain to my clients and veterinarians too. I mean, I don't know why, and this isn't new, and we have been dealing with this for my whole career, and certainly
mhm,
longer. And it's the scar issues, the scar
right,
tissue. So years ago, I came up with it's a simple analogy, but it's the analogy of spaghetti. And we know what gives
right,
that tendon its strength and stretch is the parallel alignment of type 1 collagen fibers.
hmm
And I tell my clients to take that handful of uncooked spaghetti and just stand it up. And that's what allows those tendons to stretch and have their reach their tensile strength. And when they're injured or damaged, they heal with scar tissue. And that scar tissue is like cooked spaghetti, not in terms of hardness or softness, but in terms of just that random mesh of fibers. And at that junction of
right,
healthy and unhealthy, that's where we get the chronic recurrent tearing of those fibers. And it just there was just nothing to get rid of it. In the old days preceding your career, we had a drug on the market called Baptin, and I don't know if you've ever heard of it or familiar with
heard
it,
of it.
but it was a lysyl oxidase inhibitor, and the purpose of Baptin was to prevent that collagen cross-linking. And we used to inject it in these tendons and suspensories. The horses got sore as heck, and I think there was some validity to it. The premise was preventing that scar, preventing that development of type 3 collagen. And it was taken off the market for a number of reasons, but we have identified for years it's just that scar. And back in my day, 38 years ago, everybody was, cutting proximal check ligaments for SDF lesions to take that
hmm
scar SDF and try and make it longer, lengthen that functional muscle tendon unit by cutting a proximal check, and not dealing with the scar. And I've told people for the last few years, there's just going through the hall exhibit hall, the AAP, there's lots of stuff out there, but this is the only thing that functionally, physically removes it, sucks it out, and then what? So that's been our game changer in our hands. And y'all get pretty horses in Georgia, I'm sure. We get Wyoming, as you know, you live there, is held together by
Yeah,
barbed wire. So we get some of the
right.
most severe injuries in the world. And yes, we get our chronic suspensories, degenerative suspensories, and our token draft horse or two, or warm blood with degenerative behind suspensories. But every one of those cases has responded, every one of them, and so we're pretty impressed with it.
Now, I use a similar analogy because I'm kind of like you, keep things simple. And I can remember I graduated 2009, so 17 years ago. And that's when regenerative medicine and rehab was just starting to become a thing. Like it was fairly newer. And again, I go back and look. The whole point of regenerative medicine, the whole point of rehab, is to try to minimize that scar. And that was, we're looking with those techniques. We're talking about minimizing.
Mm-hmm.
Now with Tenex, we're completely removing it, and that is truly the magic on this. So, and I guess I'd like to start, if we're going to get into uses of 10X and where we're going, I think we first need to talk about like chronic versus acute injuries on these tendons, and then what's going on when you have an acute tendon or the ligament. We'll just use tendons, and just know that ligaments have the same application. But I think we need to talk a little bit about when we have an initial acute injury, when does it become chronic, and what makes those two different injuries different.
Yeah, and I guess from my standpoint, I think it's two sides of the coin, right? I mean, you don't start with tendinosis at some level. It's always an itis, an inflammatory response,
Right.
and when that if it's tendonitis, whether it's an acute strain or overuse or an acute injury versus repetitive trauma, repetitive overuse, age, as I'm on Medicare now, and just that low level repetitive trauma, we get into the chronicity of tendinosis. Uh, Tenex is not indicated in the acute tendonitis case. It's
Right.
indicated in that once we're in that repair phase of healing, which in the human literature, um, 45 days is kind of minimum. We've been kind of saying, okay, treat the acute tendonitis if we have an overuse, a strain. If those tendon fibers are going to strengthen and increase and remodel and heal and still be functional and the horse is sound, they're not probably 10x cases, but most of them end up being 10x cases. And so after 60 days into that repair phase, um, then it's indicated. Two points. One, to your earlier regenerative, we did some of the very first stem cells. Not bone marrow aspirates that Doug Herthel started back in the day. But I remember in the early 2000s, we had some of the very first um, adipose cells, and I had some beautiful, beautiful ultrasounds on core lesions in Rainers, and they all fell apart. And they all fell apart because
Mm-hmm.
they just recurred. And I had beautiful ultrasounds, and the people are happy. And gosh, these stem cells are just great. And there's a place in the world for them, absolutely. But
Mm-hmm.
it's just the scar, um, and which is just, of course, our big nemesis. So we're waiting 60 days into that repair phase. And in the old days too, because again, I'm much older than you. We had a horse with a suspensory or a tendon. We would just tell people it's a year to heal it. We're going
Mm-hmm.
to rest it. We're going to walk it. We're going to initially blister the hell out of it. We're going to pin fire it. We're going to split it, cut it, drain the hematoma. There's a thought, because
Mm-hmm.
those growth factors are of no value. So let's suck them out of there or wash them out of there or drain them. Um, and we've just run the gamut on everything, and then you'd get a big fat scar or a big old chronic lobo, and 65% of the time they recur. So
Mm-hmm.
this, it's just changed it, and it makes sense. And I go back to Dr. Mori. After 30 years, there's got to be something different that we're doing. This is the foremost orthopedic surgeon on the planet,
Mm-hmm.
and he was humble enough to say, "What the hell?" you know, and that's just that impressed me more than anything. And then the science speaks for itself. So,
I can remember that in the early days of a lot of the regenerative and the rehab, going to a meeting, and there was this group talking about it. And again, when I was in vet school, same thing. You just let rest these horses for a year, and they told you like 65% are going to return to injury. And so I was going to these talks, and I remember one of my friends was like, "Dan, like, why are you going to do that? Like, that's a bunch of hocus pocus." And I was like, "Well, what we're doing is not working. Like, what we're doing isn't working. So what are we going to like? Let's go find out what somebody else has got to say." And so I think like that. There's got to be a better way. I think that's where every great discovery comes from. That's where all great things start. Somebody saying there's got to be a better way. Um, and I'm glad you brought up the chronicity issue in these tendons and ligaments, because that's something that I think a lot of people don't think about. Is every time you're working these horses, every time you're using them, when these athletes perform, you're getting some type of low grade trauma, and eventually that trauma will be more than what that structure can tolerate, and that's when we kind of get into these chronic tendinopathies. Um, and those are the ones that are truly the most difficult to treat. In my experience, it's almost like the core lesions can sometimes be easier than these chronic low grade tendinopathies, as far as getting those horses sound. And that does speak back to what you were saying about the scar. So, um, looking at Tenex, like um, what is kind of your, like, if you're going through your you're trying to decide when to use it, what's kind of your thoughts? Is like, all right, this is when I need to reach for 10x, this is when I need to go a different route. What are kind of some of your decision factors in that?
So our practice is a little bit different. Okay, we're largely referral based. Horses have been through their acute and prolific phase of healing, and we get horses in 30 days out to 2 years, 3 years out from
Mm-hmm.
injury, and we get the worst of the worst. So we don't have a lot of these acute injuries. A horse that comes up sore after a jumping event or a cutting event. We do have those, and we treat them as acute injuries, and you know run the gamut with them. But largely the ones we get are post 60 days post injury. So if those horses are lame and our ultrasound patterns are ugly, and again we get stuff with just fibrosis that's calcific and chronic, and
Mm-hmm.
you see deep flexors that have either been just strained, and it's truly a degenerative tendon that's filled in with calcific debris, or a bursa that's been injected a bunch of times. And look at our high suspensories. How many high suspensories did we cause from injecting depot into hocks for for decades? You know,
Right.
and following our needle track out. Um, how much of it's iatrogenic? I think a lot, but
Mm-hmm.
so we get those more chronic cases, and the vast majority of them we feel are appropriate for
Mm-hmm.
for 10x treatment, and our clients have been remarkably willing to do it.
Mm-hmm.
It's the simplicity of it, single procedure. I've not done one horse twice. There have been a few human cases that have been done twice. I've never done a horse twice. It's a once and done procedure, and I just had one last week owned by a dentist, and terrible chronic fibrotic deep flexor tendon that been there for 9 months, and he called me that just after the first bandage change, he said, "I cannot believe how well this horse is walking." Just,
Mm-hmm.
just they're immediately relieved to get rid of that scar and get rid of that free collagen. So
That was what blew my mind, because normally when we start on treatment, I may not jog these horses again for 60 days, but the first one I had come in for a 2 week follow up, I was blown away by how comfortable that horse was.
yeah,
Owner was telling me the same thing. Like, they said, yeah, we did the bandage change, and I mean, was walking better almost immediately. So
yeah.
it is truly
Well,
impressive.
and it's scary too. Rich Redding told me, he said, "Gosh, when you do your first ultrasound, some of these, it's a cavitation effect, so you're sucking out all this debris, and you're going to have a big hole in the tendon." And the first time we looked
Mhm.
at it on ultrasound, it's like, holy cow, um, what's this going to do? And again, you go back to filling in with normal collagen at normal ratios at 90%
Mhm.
type 1. And I had a recent rope horse. This kid was roping, and actually was moving cows on a rope horse, and this thing was just frayed, like 90% destroyed SDF. And the horse was so unstable in my view. I I would not even allow this kid to haul this horse home from Wyoming to Utah for Christmas. I'm like, this horse cannot travel, and
Mhm.
even in a Kimsey, I'm going to just I kept the horse, and Kim said, we're gonna keep this horse here, and I 10x'd him 60 days later. They're riding that horse now. This is in December,
Oh wow.
and
Wow.
and it's just been amazing, amazing, and not just in those cases, but really rehabilitating. We've had horses 2 years out that,
Mm-hmm.
and some chronic degenerative suspensories and draft horses, and we're going to be doing a study on with a nonprofit in Texas on rehabbing some of these degenerative suspensories, and I've done a couple draft horses. You go through a lot of probes, microtips doing this, but you can rehab these horses, and they're just remarkably comfortable.
So let's talk a little bit about the procedure itself, because I think a lot of people wonder. That's always the first question I get. Like, what does this involve? I know you talked about trying to do it standing. You did your first one standing. I attempted my first one standing, and I'm like you. I lay them all down now. It's
Yeah,
quick and short, but
two things. One, um, it doesn't need to be. It's not a hard procedure. Our average cut time, surgery time, is 2.5 minutes.
right.
Never more than 5 minutes. We do most of ours under just quick IV anesthesia. Can be done out, in a clean room, or even out in the field if you needed to do it. You do not need to be a boarded surgeon. I tell my dear friend Kurt Solberg that if even a radiologist can do it, so it's that simple. Even a radiologist can do it, and Kurt's done a ton of them. So and
Kurt
Kurt's
needs
much.
to hear that.
I know. I tell him that to his face, and he's much stronger than me, and he's a ripped guy, so I can tell him if even a radiologist can do it, anybody can do it. So don't need to be a boarded surgeon, don't need to be in a surgery suite. Just we do most ours just under triple drip. Prep them. We use number 11 blade, make a stab. We're certainly ultrasound guiding our focal lesions, but truthfully, if I have a diffuse deep flexor that is going from, let's just say, 2A to 3A, and I've ultrasounded it, I'll just mark it, and I'll just mark my stabs, and some of them I do not ultrasound guide them. Most of them I recommend that you do, but I've done enough of them. I'll plan our stab incisions. We'll just stagger them. We'll just on the 2-inch microtip, we'll just make stab 2 inches apart, and have very good luck that way. But we do recommend, as you're learning to do the procedure, to do it ultrasound guided. Some of the nice newer ultrasounds, we've got a Mindray at the clinic, and it can just have a needle guide software on there, and it makes it really nice and easy to do. So the procedure uses ultrasonic energy to this microchip oscillates at 26,500 times a second, and it just pulverizes that scar tissue and sucks it out. And we used to be a lot more probably conservative until I started looking at some of the human videos, how they're doing people, and they are just very, very aggressive with their microtip. And the beauty of it is it doesn't affect healthy tendon. It bounces off, fibers bounce away, so it doesn't affect healthy tendon. It only busts up the scar. So again, it's a very, very safe thing. The other thing we'll talk about in a minute is the antimicrobial properties of this, and bacteria can't withstand the ultrasonic energy. So there's other indications we'll talk about, and we're getting ready to publish a few really neat cases as well. But basically the microtip, we use the TX2 microtip, the 2-inch soft tissue probe that in most of our tendons, and unless we have a really, really bad calcific tendon, we might use the bone probe, but make a stab incision number 11 blade. Just you'll hear this machine, you'll hear the ultrasound. Sound like we use the medium settings on most of them, and it'll sound like a dental scaler, and you'll just hear it just kind of chiseling away, and as you're cutting through this, that fibrotic tendon, it just kind of feels like butter at the end of it, and it's just a really neat feeling. So we do that. I usually don't use sutures unless I hit blood vessels, which I'm really good at doing, and if so, I'll put a staple in them, wrap them up. We do use the Pronistan antimicrobial gel on all of our cases. Keep them in clean bandages for week to 2 weeks, and we'll talk about rehab a little bit later. But real simple procedure. Honestly, it takes longer to prep the horse and set up the machine than it does to do the procedure. And we usually block out total 30 minutes of our day to do one, but it's you just do it under triple drip, very easy. So standing ones, if there's an indication not to do it down, maybe in a draft horse or a horse that's tied up, or any other indication not to do it, just do a high block, and I have found it well tolerated. I'm just more of a more cautious in my advanced age.
Yeah, no, I attempted my first one standing, but my case selection may not have been the best as far as breed, but we ended up just using the same anesthesia you'd use for castration. I mean,
Okay. Yeah.
and like even yeah, I've done 3 of them down in the Cayman Islands, so no OR, no knockdown room. I mean, it was us in the grass, and
Okay,
I
so
can
my
remember
wife, my
those.
wife is in the background. Wait a second. So my wife is
Yeah,
in the background, and you did 3 in the Caymans, and you did not invite us to show you how to do it. We're
I
just to
should
watch.
have.
You should have, especially like
Yeah,
January in Wyoming. So
no, it's a good place to be in January. But yeah, I remember it was. I've done 3 10Xs down there and 1 arthroscopy in the grass. And I can tell you that it's the only time in my career I can remember having to watch the sun, and I had to wait for the sun to get in the right position so I could see the screens. So it was the
yes,
first time like it was a weather dependent
well,
surgery, but
yeah,
that was the hardest
yeah,
part, I think.
I have been another discussion, but I've been fortunate to do surgery in the Himalayas twice, in the
Oh
in the
wow.
Kingdom of Bhutan. So
Mhm.
I had 3 years of training by a human surgeon and he was a head of a battleship hospital in Vietnam, and he said always have a plan B, C, D, E, and sometimes F. So yeah, it's always fun to operate in different places. But the point being
Yeah.
that 10x
Mhm.
can certainly be done out in the field, and just need a power cord for your machine, and just aseptic technique, and you'll do fine.
Mhm. And
And back to the standing point. Also,
right.
I find it easier to insert the microtip in the de-weighted
Yes.
suspensory, or so if you are doing one standing, um, either have someone hold the leg. In the article that I published, Rich Redding's doing a horse standing weight bearing. I find it easier to advance the microtip in the non-loaded um, tendon, or non-loaded limb. So it's easier, but then it's harder on ultrasound to to follow what you're doing. So we knock them
Mhm.
out and just get them done quickly. So
No, we do the same thing for the same reasons. It's much easier in the unweighted leg, and then they move far less
yeah,
laying down. So it's
yeah,
not you just your accuracy increases when they don't move as far as
yeah.
hitting
And
them.
I don't see that there's a great way to do a high suspensory in the
I
hind
don't
limb
think you could.
and the standing horse. So knock them out. It's easy, one and done.
Hmm. Yeah. So let's talk a little bit too. Like we've talked about these chronic tendinopathies, but you brought up a great point about these calcitrific tendinopathies. I actually did my first one that had some dystrophic mineralization in the oblique sesamoidean ligament, and I can remember those are usually the most frustrating cases because you've got this mineralization in there, and it seems like every time you get them to a certain point, they start re-injuring around it. They start to get inflamed around that. It almost acts like a foreign body inside of that tendon or ligament, and we didn't have a great solution. But we used the on ours we did use the bone probe for this, and it was unbelievable how well that worked and how well that horse is doing now just to go in and remove that. So I'd like to talk a little bit about those as well.
Sure. I have used. It depends on the amount of dystrophic calcification, but I have used the TX2 probe on some of them, but the bone probe certainly is appropriate. And again, you're not advancing it 2 inches or 1 inch. You can go in and just a guided stab right to the lesion. So the same principle applies. You're just pulverizing the tissue and getting it out, and really just the rehab. And I don't. There haven't been studies that have shown that the increase in stem cell recruitment. We suspect that's happening. Um,
Hmm.
we suspect we're rehabbing local, microcirculation into the tendon, but um, it's hard to study those horses, right? You're rehabbing them and then just kill them and slice them up, and see what happens
Mm-hmm.
under a microscope slide. But we think that's happening. And but in those focal pinpoint calcific cases, it's really appropriate, just like you and oblique sesamoids are hard to do, and absolutely a case for it as well. In humans, they're doing a lot with enthesis. I mean, lots of heel spurs. Lots of I had actually a small animal client or a colleague call yesterday about doing an enthesis in a dog's shoulder, and we'll talk about the small animal use in a minute, but very applicable as well. So the bone probe is a bit larger, and they actually have their second generation console, which is not available to veterinarians yet, does have a 3-inch microtip, and it is a bit beefier than the TX2, and
Mm-hmm.
it's labeled for soft tissue, which I love, but it's I think it's 11 gauge needle or 12 gauge needle. I'll get that for you, but
Mm-hmm.
certainly can use for some calcific uh, tendinopathies as well.
Well, and that was one of the things I was wanting to ask too, because I've been wondering if you've had any experience using it on like some of these proximal suspensories with the old Waldenstrom fragments, or we're dealing with those in insertional desmotic cases, the enthesiopathies in there, where that ligament ties into the bone, and you get a very reactive bone. You get a lot of bone proliferation, or even these small avulsion fragments that come off. Have you had any experience using it in those cases?
Yes, and you'll pulverize the bone and get rid of it. I mean, it's going to act just like a heel spur in a person.
Mm-hmm.
And on Achilles tendon, it's on a plantar fascia, which I have had, and they're miserable, and they don't go away.
Mm-hmm.
You physically remove them, and yep, very applicable.
Okay.
And we'll talk a little bit about it, but I did use bone probe since this will segue into it.
Mm-hmm.
I've had 2 nasty septic coffin bone
Mm-hmm.
osteomyelitis cases, and I've used that bone probe to cure these horses with the C word. One was sent up here for an amputation case from Alabama, a completely sound horse. It had a 2 centimeter lytic coffin bone right just below the joint, and remove this big sequestered bone. It's perfectly sound horse today. That being said, that bone probe will sterilize it. It will pulverize that tissue, and it will suck it out. And if the avulsion fractures, it's going to heal back, and you're going to have this chronic, in effect, spurring and calcific proximal suspensory. Just remove the damaged tissue.
Mm-hmm. No, I do a lot of septic P3s down here with osteomyelitis, and we've always done the old school. I've always curated those, had great success, but yeah, I've really been considering, since you told me about those cases, using that bone probe after we removed the sequestrums to go in and follow that up, just because of the antimicrobial
Yeah.
aspect
So
of it.
yeah. So we're getting ready to publish 2 cases. One, uh, uh, both similar cases. One horse sliced his hoof, lost about fourth of his coffin bone, and the other was this case from Alabama. The guy flew the horse up here. It was just a wonderful gentleman. Called horses at a veterinary school for 2 months and scheduled to be euthanized in the morning. And he called about prosthetic limb, and I said, "We'll go to our website and read about it, amputation prosthesis." I'm glad to do it, but um, the guy said, "I really want to do it." And I said, "Well, bring the horse up, and we'll let him rest a few days and get it done." He called back and he said, "Doc, I don't think he's going to make the trip." And I said, "No, I'm sorry." He said, "So I'm going to FedEx him." So he did. He FedExed his horse to Billings, Montana. And then my wife got involved, and she said, "Is there any way you can save this horse?" And I don't know if you have this experience in your household, but if Mama's not happy, nobody's happy. So I'm like, "I'm going to
Yeah.
have to save this horse." He says, "No, try and save this horse. Is a venogram good?" And I don't know how with this rotten coffin bone. So I read it to my lovely wife. I called Dr. Morey. I said, "Bernie, what do you think?" And he's, "Well, I think it's worth a try. We can always cut it off later." So the guy's riding horse today with 4 legs, his own legs, and I had to eat a little crow, but saved the horse, and everybody's
That's
happy.
fantastic.
but we're also using it to our surgeon friends out there. Um, we do a lot of fracture repair in our practice, and if we have an open fracture, we're debriding all of our fracture edges with the Tenex probe. Doing our prep, doing our Pronistan rinse, and we're debriding these edges. Even we had a little horse come down from, I think, British Columbia a couple weeks ago, open cannonbone fracture, open in the cast, type 3 open fracture, and totally healed fine. And so we're using it. We're putting implants in our open fractures. We're Tenex debriding our edges. You don't put metal in a infected environment. I actually agree with that. So let's not have an infected environment anymore.
Yep.
So we're sterilizing that field, and that's the beauty of the microtip. And I know we were talking about other indications, but we segued into it. So there's neat indications for this procedure. So
that actually makes a lot of sense, because I had not thought about that. But if you can sterilize the edges, your success rate's going to go up dramatically.
Right. And you get a cannonbone that's been denuded for a couple of days, in a splint or cast, and it just freshens up the edges wonderfully. And so we're loving it. And in the cost of a fracture repair, it's pretty minimal addition for the microtip cost. So.
No, it's pretty fascinating technology, and like I said, it goes back to sometimes the simplest solutions are the best. If the scar is the problem, just get rid of the scar.
Yeah.
And this lets us do that. So I did want to talk a little bit about, post-op care, what that looks like. So you've gone in, we've done the 10X. What can people expect next? Like, kind of what is your protocol? What are we looking at? Like, let's say, kind of break it up, first week, first 30 days. And from there, what do you typically do?
Yeah. So again, we're in Wyoming, right? We're not in pretty Georgia and with pretty dressage horses and pretty hunter jumpers. We're in Wyoming. So typically our horses are kept in a sterile bandage for a couple of weeks. We don't use antibiotics. They're usually on NSAIDs for 3 to 5 days after the procedure. And we put them in a probably 20 by 30 pen or smaller, or just a big stall. Start walking them for about 2 weeks, and then we'll start hand walking them a few minutes a day. And after 30 days, they go into a little bit bigger turnout, and with hand walking. And typically 60 days out, these horses are back in some kind of controlled riding under saddle at a walk, and just control rehab. Obviously, depends on the type of lesion. It's not. There's no protocol for every case. If you've got a big, fresh core lesion that's friable, I think the bottom line, it does depend, right, on how severe if we've got a focal oblique desmoid ligament versus a really diffuse STF that's just ready to fall apart. It depends a little bit on how they're on our rehab. So I don't have that answer, but most of the horses in our study were back to some kind of activity in 7 weeks post-op. I know some people have gone longer, and I've got some friends in Wellington that are doing it, and depending on the horse and the extent of the lesion. So it just depends. If you have a huge voided space, be sure your ultrasounds are filling in nicely, and then just response to therapy. We will talk, or maybe segue into the regenerative part at surgery. I didn't use any regeneratives in the initial study. I didn't want that variable input. In the human space, the biggest reason to not use regeneratives is cost. And where we might charge a few $100 for PRP, they can charge thousands of dollars for the same PRP system, and it's not covered by insurance. So if people want to do it, I think there's a place for it. Just be sure that you are using a low leukocyte PRP and not restarting that inflammatory response. And I have some good colleagues that are using other biologicals, and I think it's probably appropriate, but I don't know that it's necessary. That's just my opinion, and I don't routinely use them.
So we're typically following up about 2 weeks post-surgery. with some type of regenerative, whether it be Renovo, PRP, stem cells,
Yeah.
Shockwave. Is that sort of if you're going to use one of the regeneratives, is that sort of your timeline, or are you doing it at the time of
I
surgery?
just
What's
at the
your
time. Yeah, just at the time. Yeah.
Okay.
And we have had, and again, we're gathering information. They're going to be presenting a number of cases at ACVS this year from CSU, and I think that it's going to be interesting to see what is the best thing. I don't think we know that yet. Um,
Mm-hmm.
Relatively, probably a few hundred cases that have been done in the horse up to this point, between all of you and I and all of the people at New Bolton and all of the places that I'm familiar with that are doing them. Maybe 1,000 horses, but let's get the
Mm-hmm.
information together and make the best decision for the horse. But we routinely haven't used regenerative therapies in our practice. And again, our population is a little bit different than yours, and sometimes finances dictate that in our practice a little bit. But we initially start with rehabbing the tendon by getting rid of the scar.
Well, and that was one of the things I wanted to ask is, like, again, I'm just, as we're kind of going through this, I'm sort of thinking through is we know having some movement on these horses can decrease the amount of scar that gets deposited. And so I typically have them moving. I mean, I'm definitely not turning them out, but I'll typically have them in some larger, not necessarily the strict 12 by 12 stall rest. I'll have them in a little bit larger pens.
Yeah.
I'll have them making sure we're hand walking shortly after surgery. Are you doing something similar, or
Absolutely. Yeah. They're in a 25, 30-foot pen or, right away. So they're walking themselves throughout the day. Absolutely agree. Don't stick them in a stall. I mean, unless you have, if you have an SDF that's ready to fail, they're not ready for Tenex. Okay. They need time to get some support, but no, it's remarkable. And do everything else right. I mean, I am, full disclosure, part of another company in California that we have a patent on the HGI boot, and we're modifying the HGI boot for some controlled rehab. And there'll be some information on that in the next year or so. But this has just been the foundation of all of it. I mean, everything's gonna. Again, back to your comment earlier about the old regenerative lectures were about controlling scarring. We want to get rid of it. So is get rid of it,
Yeah.
and we could save a lot of steps along the way. But it's been amazing to me the horses that have just had lesions that you just didn't think they were going to ever do well, and just a single treatment. So it's been a game changer for us and at a lot of levels. So.
I'll tell you some of my favorite ones are I've got a few trainers that have been a part of us doing Tenex on some of these chronic tendinopathies, and they've seen the results. These horses that weren't getting sound, and it's actually interesting. I'm going out to look at one today that's got a chronic branch, and basically we're going to look at it, and if it looks like Tenex can help, they're going to take the horse to give him another career, because they're like, Dan, I've seen you fix them. I've seen what the Tenex can do. I've seen you be able to fix things that couldn't. And it kind of, I didn't really think about it till we were talking on the phone about it the other night with this trainer. Is that's a horse that wouldn't have a career, that would just really everything, like the horse was done, like all hope had been lost. And then when you look at what Tenex does, and it's able to give that horse that second chance, give that athlete a second chance, because I'm a big believer. I think these horses are athletes. They like to perform just as much as human athletes. I mean, they truly enjoy it. They love what they're doing. A lot of them do not retire well. And so having a technique like this that can give that horse a career back is, I did not think I would see that when I first graduated from vet school. I didn't see that happening.
Yeah, no, exactly. And we were all taught. I mean, I grew up in Ohio, and went to this place that had just opened in 1987. They're called Root and Riddle. It had just opened in 1986, and
trained there as well.
Yeah, so we're all taught the same thing about the tendon injuries, and we're rehabbing these horses for prolonging their career or giving them, another level. And
Hmm.
at our top level horses that 3 years, I, you know, you're exactly right. We're prolonging their career.
Hmm.
Absolutely.
It's pretty fantastic. So, what else? Is there anything else you want to make sure our listeners know or have a good
Yeah.
understanding of that we didn't cover?
I think that there's a couple things that are really important in the veterinary space. And again, just pushing the envelope with, hey, what else is out there? Tenex was approved by the FDA for non-healing diabetic foot ulcers in humans
Oh,
a few
wow.
years ago, and I my ears perked up. My late father was a podiatrist and dealt with those horrible lesions in humans and chronic osteomyelitis, chronic scar formation, chronic poor vascularity to these wounds, and 25% of humans with diabetic foot ulcers end up with amputation. And of
Hmm.
course, my ears always perk up when I hear a good amputation story. And in the Tenex cases, and using the bone probe and kind of a purse string approach around that lesion, they're just going in and just 3 or 4 stabs in the periphery of that lesion with just the bone probe, single use. Um, the results are, I don't have the numbers, but the results are just incredible in curing these ulcers. So that got me into using the bone probe in these osteomyelitis cases in horses, and that's when you know my my lovely wife was, demanding that I not cut this horse's leg off from Alabama. And hey, can we use that same really principle in treating that osteomyelitis? So in our pedal osteomyelitis cases or any osteomyelitis case, absolutely, there's a place for this bone probe, and it is a very, very cost-effective way. We can stuff all the beads in the world in there. We can
Hmm.
scrape an infected bone full of whatever, E. coli or strep zoe or whatever,
Hmm.
and scrape it, and we still have E. coli, and we can, you know, put whatever fluids we want to, and they end up on the floor. But to kill the bacteria this way is and it's been remarkable. So there's lots of potential indications. I would love to try it on a nasty shoe ball. I've never done it, but if you have one, certainly try it and follow the protocol for that. Um, Diabetic foot ulcer, and there's tons of literature right now on the Tenex Health website. Um, and the other indication is in small animals, and I know we don't at present do any small animals, but Dr. Mori had always contended that in calcific biceps tendinopathy in working dogs, military dogs, um,
Hmm.
there's an indication. And I did one Achilles tendon in a large breed dog last year for a veterinarian. Um, that did well. I just got a call the other day on a Labrador with a supraspinatus enthesis, and I think there's lots of indications in the small animal space that we need to be aware of. You can use largely the same microtips and certainly the same console. So those veterinarians that are in mixed practices or equine veterinarians that can help a small animal patient, I think there's a big place for it. Um, so that's important. The new console is just been approved and released a month or so ago in the human space. That it's going to allow just a larger microtip. We don't yet know when it'll be available to veterinarians, but it's a totally different console. Um, so the new microtips will not work on our existing consoles that you and I have, but we're getting information on that, and it sounds like we'll be able to try that on some horse cases soon. Um, in full disclosure, as you all know, there was no ability to get Tenex into the veterinary space. It's class 2 device, and the company had they wouldn't sell it to veterinarians. And I really, really wanted this after I did my first case. So my wife actually had to start a small distributorship so that we could actually purchase it, and that's how it's getting purchased in the veterinary space. I am a
Hmm.
non-compensated consultant for Trice Medical that owns Tenex, and we're just glad to help you guys. Anybody, just walk them through it. We do have a small video that we can send in a Dropbox to you all as to how we do the procedure. But it's very, very, very straightforward. It's a very easy learning curve, and if I could
Mhm.
do it, Selberg, I'm sorry, my radiologist friends can do it. Anybody can do it.
You can pick on Kurt on the show. You can pick on Selberg.
Absolutely,
He's a
we
good
love
friend of
Kurt.
mine. So
We love Kurt, and I'm not the
yeah.
smartest guy on this call, but we do a lot. So my wife Kathy owns the company, and be
Hmm.
nice to her. She's a great resource for just
Yes.
information on it. And company ships direct. They just would not sell to veterinarians, and we tried every which way. But um, just get hold of her at Yellowstone Animal Health, or our office number, the 307-527-6968, and we'll get that information to you and whatnot. So, and we're glad to teach you. I've done it by FaceTime. I've done it in person, and we've been
Hmm.
fortunate. I think we're in about 8 veterinary schools now,
Hmm.
and a bunch of big clinics and a bunch of very good smaller practices like mine that are able to use it, and we're getting calls all the time. So I think it's going to be the next, not the next big thing. It's just the thing we've been dealing with for my whole career as I
Hmm.
enter my 39th year next week. Um, you know, there's got to be a better way than what the heck we've been doing. And that's, again, I
Hmm.
go back to Dr. Morey from our first comments, and that takes a bit of humility and rethinking. And if we're doing the same thing and it's not working, let's do something different. So Tenex has changed our practice. It's saved a ton of horses. It's been a godsend for the horse, and thank you for helping get the word out.
No, we really appreciate you coming on. I'm hoping to get the word out more so we can help more. And y'all have been absolutely great to work with. I mean, you've helped me a ton from when
Thank
I
you.
started tracking down a unit. I remember calling Trice Medical and like, oh, you got to call Yellowstone. I was like, okay. And your wife was great to work with. You've been fantastic. Every time I've had a question, you picked up the phone, talked to me. It's been a fun. It's really been a fun thing to learn because you're helping a horse. It's not difficult. I tell vets all the time, like if you can do an ultrasound guided injection, you can do 10x. Like if as long as your foot works to hit the pedal and you can do an ultrasound guided injection, you can 10x. But it's been a fantastic procedure. And like I said, I'm glad you got it into the veterinary space because I really don't want to practice without it, to be
Well,
honest.
thank you. And I am married way up, but again, kudos to
I
my
just
dear friend Rich Redding. Really was instrumental in some of the earlier users. Haynes Stevens was a very early user as well, and some of the people that really looked at feasibility. Can we do this in the horse and do no harm? And it's been a brilliant thing. And I
Mhm.
just got as we're talking today, I go back and look at all of the things we used to do, and
Mhm.
it's humbling and a little bit embarrassing as to some of the ways we treated these horses. We can increase circulation to a horse. I mean, we do
Mhm.
it with a lot of ways to increase circulation, um,
Mhm.
and just keep it simple. It goes back to that spaghetti analogy and the scar,
Yep.
and my dear friend Dr. Morey, and we're grateful that and Bernie too is a very big supporter of veterinary medicine. He loves what we do in the veterinary space. He loves the freedom that we have in the veterinary space, and he's a very accessible man and a legend. He spoke at AEP 2 years ago with us,
I
and
remember that.
he's a dear friend. So just he's available too as an added resource, and I'm glad to help anyone connect with him. So. But
I'll
Cayman
tell you,
Island. So yeah, you
Cayman
really
Islands.
training in the Caymans. I'm thinking, Dan, that's just those horses are different and they're different challenge. I really think as you're younger, uh, those cases that are booked from about December to February, I think we really need to be play more active role. So just saying.
I absolutely wish to get you to come down. It's a tough place to go in the wintertime. I can tell you, it's difficult, but I tell everybody practicing down there is like stepping back in time because the medical facilities involve tents with screens on them to keep the flies out, and yeah, a good patch of grass and making sure the sun's in the right place so you can see the screen when you're working. So
Perfect.
but I tell you, the people down there are fantastic, and it's a lot of fun. So,
Love it.
well, Ted, thanks for being on this morning. We really appreciate you waking up and jumping on this podcast. This is one of those, when we first started the podcast almost 2 years ago. This was actually one of the first ones that I really wanted to do because I'd just gotten into Tenex at the time. I was so excited about it. I wanted to tell the world. So thanks for being on here today and helping people walk through it. So
Grateful for the invite. Thank you so much. And
okay.
I look forward to working with you guys, and everyone, please feel free to reach out.
Absolutely. Well, thanks to all our listeners out there for listening to our podcast. And April, thanks for filming this. Casey, thanks for doing all the editing and making us sound like we know what we're doing. So we appreciate, like I said, we really appreciate all our listeners. And from all us here at Countryside Equine, thank y'all. Take care.